Thank you very much, Sean, and good afternoon. And thank you to everyone who has joined us for a very exciting teleconference on the impact of health IT on workflow. Before we get started, I have a few housekeeping items that I need to go over. First of all, I'll be doing some welcome and introductions, then we'll get into presentations and we'll have a Q&A session. The slide set also includes information on how to obtain CME credits, so you'll see that at the end of the presentation. Keep in mind that everybody should have received a copy of the PowerPoint presentation ahead of the teleconference. If you didn't, you should receive one immediately following. First of all, I need to disclose that I need to state that neither myself nor the presenters have any financial interest to disclose, and continuing education is being managed by the PESG. PESG, AHRQ, AFIA, and RTI have no financial interest to disclose. We will be using the Q&A feature of WebEx to submit questions. We will be holding all questions to the end of both presentations. Please take the time to familiarize yourself with the WebEx interface, and you can submit questions to all panelists using the Q&A feature. On this slide are the learning objectives for today's teleconference. I will leave those on while I give you a little bit of background. We have two great presentations for this afternoon, and these are from two projects that were funded under the same initiative. We wanted to fund projects that were explicitly focused on understanding the relationship between health IT implementation and workflow when health IT was being implemented to support practice redesign. Both projects also had a specific focus on small and medium-sized ambulatory care settings where research on this topic was lacking. Without further ado, let's move into the presentations. Our first presenter this afternoon is Dr. Elizabeth Siemens, who is a health service research scientist, research director of the Center for Clinical Translational Research, and assistant program director for scholarly activity, internal medicine residency program at Billings Clinic in Billings, Montana. Dr. Siemens also serves as part-time faculty at the University of Montana, Missoula, and Montana State University, Billings. Dr. Siemens received a PhD in Health Services and Policy Analysis from the University of California, Berkeley, and an MPH in Population, Family Health, and MA in African Studies at the University of California, Los Angeles. She also served as health educator, nutritionist in Niger, West Africa, where she worked with traditional birth attendants to improve the health of women and children. Dr. Siemens' area of research interests include chronic disease management, health information technology, palliative care, childhood obesity, care transitions, rural health, information technology, mental health, and complexity science approaches to behavior change in healthcare. Dr. Siemens.
Thank you so much, Teresa, and welcome everybody to the webinar today. I'm going to talk about our study that examined the relationship between health IT and ambulatory care workflow redesign. I'd just like to acknowledge my co-investigators as well as our technical expert panel that advised the whole project. In addition, I wanted to acknowledge it was a large team, our research assistants and research analysts, our site coordinator, and of course all the clinicians and staff at the participating organizations and sites, and they know who they are. So a little bit of background. We've had a lot of hopes for health IT, and they include facilitating access to patient data, improving adherence to guidelines and to best practices through embedded decision support, and engendering beneficial workflow and process redesign. In reality, we all know we've had implementation delays and budget overruns. We've seen resistance by end users, and sometimes a failure to produce anticipated results. We've also seen some unintended adverse consequences associated with health IT. In relation to workflow specifically, some of the negative impacts have been due to deficiencies in the design itself of the health IT, problematic implementation processes, sometimes misaligned end-user incentives, and many other behavioral, organizational, societal factors. So in response, the objective of our study was to understand how health IT impacts clinical work processes and workflow, and specifically to look at the causal relationship between health IT implementation and ambulatory care workflow redesign, the socio-technical factors and the role that they play in mitigating or augmenting health IT's impact on workflow, and finally, the workflow impacts of health IT magnified through frequently occurring disruptive events such as interruptions and exceptions. So we had two organizations engaged in our study. One was an integrated hospital and multi-specialty medical group practice in the Western United States, which I will refer to as Organization West, and then a community-owned health system that provides only ambulatory care to underserved communities in Eastern United States, which I will refer to as Organization East. So at both organizations, we had a total of 6 clinics participating. 5 were primary care practices, and 1 was a specialty care clinic. So the specific health IT implementations that we studied at Organization West, we looked at an update to an existing EHR, and that included an electronic homepage, medical and social history available prior to the visit, a standardized EHR-based message center, and computerized provider order entry. At Organization East, they implemented a brand new EHR, a new vendor-supplied system, and features of the new system were automated patient telephone reminders, also a medical and social history prior to the visit, enhanced clinic team communication, a referral orders tracking and reminder system, a process to monitor and report gaps in care, as well as additional templated notes. So we conducted a prospective observational study. We used a mixed methods approach, and we collected data using a number of different activities, and we collected data before, during, and after the planned health IT implementations. So we conducted ethnographic observations, and that entailed having research assistants sit at each clinic and watch for several hours the workflow, and then ask questions, so contextual inquiries about the workflow and what was going on. And it was also a way for us to identify the tasks and activities that were part of the workflow at each site. From that information, we developed an iPad app to collect time and motion data. So then we did time and motion observations at each clinic based on what we saw in the original ethnographic observations. We also collected data from log audit data, which is generated from the EHR systems themselves, and that shows all of the computer activities by individual at each site for a given period of time. We conducted semi-structured interviews, and then in the end, we took our results and shared them back with the participants through what we called member checking focus groups to get their feedback. So this just sort of walks you through the different activities in our study. So the pre-project activities, we also mapped the study sites. I didn't mention that in the time and motion data collection, we were also able to collect the location of where the activities occurred. So we mapped each site to enable us to do that. Then in the pre-implementation period, we did the ethnographic observations, the time and motion data collection, and then the health implementations, the planned health IT implementations occurred. We also did some during implementation ethnographic observations to try to capture what happened while the health IT was being implemented. We then remapped the study sites to make sure we captured any changes that had occurred along with the health IT implementations, post-implementation ethnographic observations, time and motion data collection, and then we conducted semi-structured interviews with select participants in the study and some additional. We then triangulated the results, so we took all of our different data collection activities and put them together, And that's when we fed those preliminary results back to the participants in the member checking focus groups, reflection, conclusion, and then, of course, reporting of results. So we used several conceptual models to guide our work. The first being UNIRTL's workflow elements model. And this model describes workflow as consisting of 5 specific elements: the actors, which are the people that are performing the actions, artifacts, or the physical or virtual tools, actions, and outcomes. And in a minute, I'll show you how we mapped this model to our actual study activities. We also use socio-technical systems theory, and this considers human, social, organizational, technical factors and their interplay in the environment where technology is employed, in this case, the technology being the health IT. And socio-technical theory is used to study health IT design, implementation, and use. It helps us understand sort of the fit between the technical and social subsystems of an organization. And finally, we used complexity science. Complexity science is the study of systems that are composed of multiple interacting, interdependent, and heterogeneous agents, such as healthcare organizations. And this really extended these first 2 models to help us understand the nonlinear nature of systems. So this is the UNIRTL's workflow elements model that I referred to. So in our case, for our study, the actors were the healthcare professionals at the sites. They performed actions, and those actions were the workflow defining tasks and activities that we recorded, and then the outcomes being the impacts on workflow. And additional characteristics of the actions included, were they multitasking or workarounds, and then we also focused on interruptions and that impact on the actions. So this model also suggests these other 3 elements that are out here in the clouds that apply throughout workflow. And they include temporality, which is scheduling and coordination, context, which is very important, and that's when we focused on the socio-technical factors, things like the physical and virtual workspace, relationships, other organizational factors, and these can constrain or enable the workflow. And then aggregation, which is a combination of the actors and actions, and we focused on conflict, coordination, and cooperation. So the analysis, we, as I mentioned, used a mixed method approach. So for the qualitative analysis, showed the standard constant comparison approach to identify themes. And then we used the data reduction methods to sharpen our focus on our specific study objectives. The quantitative analysis, we did a time allocation analysis, and that looked at how much time our participants spent on each task and the distribution among tasks of that time in terms of both duration and frequency. Workflow fragmentation, we looked at the frequency of task switching and assessed which study participants switch between tasks. So for example, a shorter continuous time on a task would be a higher frequency of task switching. Then we looked at pattern recognition, and that means which tasks follow which other tasks, both within and across observations. And this is where we also incorporated the location sequences of the conducting different tasks. So not just the task itself, but where the task was performed. And then we did a multitasking event analysis. And finally, an integrative analysis of the qualitative and quantitative, where we triangulated the findings from all of our different data sources. So we used several different visualizations to help us make sense of all this data. In this example, this is a time belt visualization. The top here, this top area is in the pre-period, and the bottom is in the post. Each color is a different task, and each of these lines is a different individual during the time that we were watching them. So this is the time and motion data, and we collected usually for a 4-hour block of time. So this allowed us to look at just sort of get a sense of the different tasks that were occurring, which ones were occurring most frequently, and how fragmented and sort of chopped up the tasks were. Another visualization we used was the heat map visualization. So in this example, this helps us look at what task is most likely to follow another task. And the hotter colors, so the more red they are, the more likely they were to follow a task. So for example, so again, this is the pre-period at the top and the post-period at the bottom. And the top is a list of different tasks that we were observing. So for example, the B right here was the task was dictating, and it was most likely followed by D, which is use of paper. So here it's a 43% chance that after dictating, it was followed by use of paper. And so this just gave us another chance to look at differences in areas that we wanted to drill down in our analysis. Another visualization we were able to use was this pre-post comparison. So here again these are the differences between the pre and post period, and these are different tasks. So any task that has a bar that goes out to the right meant that it increased between the pre and the post, and any that go to the left represented a decrease. So, for example, this bright green bar, this long bar at the top was computer entering, where we saw an increase following the health IT implementations, and down here, paper, we saw a large decrease. So our results. Here on the left are the different data collection activities and the number of people that participated by type in each of the activities. So we had a total of 130 unique participants, and several participated in more than one activity. We collected a lot of data, and I wanted to share the volume of data that we collected. So, for example, in ethnographic observations, we had 554 pages of field notes, which represented 366 hours of observation. Down here in the time and motion observations, we followed each of the 58 participants in this piece for 16 hours each. And so this gave us 85,800 distinct records and over 1,000 hours of observation. And then again with the audit trail logs, where we tried to pull the same data, but from the EHR itself, we had 79,000 entries of data. So the findings are organized by our study goals. So I'll remind you what our study goals were that I mentioned earlier. So that relationship between health IT and workflow, the socio-technical factors, and then the focus on interruptions and exceptions. So first, looking at the findings that relate to the first goal, we had 5 major areas that we had findings in, and I will focus on each of them in order. So we're going to start with the shifting time allocation across tasks and multitasking. So as you saw in one of the previous figures I alluded to, we observed an increased use of the computer, up to a 47% increase in some individuals at some sites. And here's an accompanying example, a quote from a provider who said, "It's irritating to me that I have to spend more and more time on the computer and less time with the patient, but I guess it's the way of the future, but I don't like it." So this shows that increase and also the opinion about that increase. And in conjunction with that, we observed a decreased use of paper, up to a 30% decrease. In terms of multitasking, we saw reductions in multitasking events. So with our time and motion data collection, we were able to have our observers click on the buttons of 2 tasks at once when we felt that they were doing them at the same time. So this table shows the multitasking results. And here on the left, this top, the ones that I have bolded here show the significant reductions in multitasking. So these are the number of occurrences per hour of a multitasking event. So in Organization West, we saw a decrease of 25 multitasking occurrences per hour to 18, and that's a significant reduction. And we saw an even greater reduction in Organization East. And then we also could look at the duration of the multitasking events in seconds. So we went from almost 54 seconds average of the multitasking event to 43, and an even more dramatic reduction in Organization East. So workflow workarounds and the impacts of health IT on efficiency are the next two findings I'll focus on. So we observed many workflow workarounds, and they were due to a number of reasons. One was just a fear of the information being lost in the system. So there was a little distrust of some of the new health IT, and these type of workarounds were usually paper or redundant paper systems. So a paper system just to make sure that the information wasn't lost until confidence was built. Some workarounds were due to the inadequate design or the setup of the system. So, for example, at one site, they wanted to order a childhood vaccination that was not yet a choice in the system. So they had to use a paper system workaround until that was fully set up or ramped up. Another example of the system's or inadequate design was an inability to order a medication dose as wanted, where the choice wasn't in there. So in that case, the provider had to put in two orders, one for one dose, one for another dose to get the total dose that they desired for that patient. And then some of the workarounds were actually in response to an inefficient workflow. So the way it was set up was deemed inefficient, and the workaround was to improve the efficiency, even though that sounds a little ironic. There are also impacts on efficiency, and they were both positive and negative. So I'll share some of the positives first. One was this collection of patient data in advance of the visit. An increased detail in radiology orders was another example of increased efficiency, and this was in particular for the specialty care clinic, where they got all their information at once, so there didn't have to be a lot of back and forth, which was inefficient in the past. An improvement in efficiency for short-term follow-up visit scheduling, and then the EHR embedded email for provider-nurse communication for non-time sensitive issues improved efficiencies. I'm going to share a couple of quotes to support that last section on efficiency. So the first one, one provider said that the collection of patient data in advance of a patient's visit, making it available to the provider, to myself at the time of the visit, has been enormously impactful in a positive way, allowing me to spend more time reviewing the data and discussing the information with the patient than actually collecting the data during the visit. And the second example has to do with the nurse-provider communication. So this provider said, I think I'm probably more effective at conveying non-time sensitive information to my nurse, which then can be passed on to a patient. So I actually enroll my nurse in more activities where they have contact with the patient directly after a visit or before surgery, and it's actually more effective. So there are also impacts on efficiency that were negative. And the one I talked about before and shared a quote with was more time in the computer, which sometimes resulted in less patient time, and that was perceived as inefficient. There are also increased documentation requirements and more structure associated with those documentation requirements. The workarounds themselves, except for the one example I mentioned where it was to increase efficiency, mostly had negative impacts on efficiency, the redundant paper systems and the more time it took. And then here's another example of a negative impact on efficiency. Why are over-the-counter medications entered and viewed in a separate location? It would make more sense to be able to view all medications in one area. So finally, the changes in computer work hours during and after hours. So this figure sums up that issue, and this was based on the EHR generated system logs, and that's what's here on the y-axis, the number of logs. And in the pre-period is the gray line, and the post-period is the red line. So as you can see, along down here, you can see the time of day, the hour of the day. So overall, there was an increase in computer use, but also there was an increase sort of before work hours here between 4 and 7 a.m. and here late in the evening. Related to this, one provider said that the continuous dictation, I think, for me, I used to try and dictate in between patients, and at the end of the day, now is when I do all of my dictation. I try and do it, but there's just no time, so I end up dictating at 5 o'clock continuously for 2 hours. So the next goal was to look at socio-technical factors and the role that they play related to workflow. So we had 3 findings in this area. The first one had to do with physical space. So we looked at the adaptation of physical movements to new workflow patterns, as well as different use of space to improve efficiency and integrate the new health IT into the workflow process. I think now I am going to play, or we're going to play a short video. So just to remind you, make sure that your speakers are on your computer. And this is the physical, this is one layout of one clinic, but I just wanted to give you an example of how we are able to analyze changes in location. So you can go ahead and play the video.
Presentation stage. The different colors represent different areas of the clinic. The dots traveling back and forth represent origin and destination points. Blank spaces mean we did not observe the providers going to that particular room. We had 16 observations in the first stage. In them, providers went to the workstation 162 times, an increase of over 30%, while the nurses' station visits increased by less than 10%.
To see if the health IT had an impact or had any changes on those actual patterns. Another socio-technical factor we looked at were relationships and their interdependencies. And we found that positive relationships were positively associated with success in implementation of health IT. And these are 2 good examples of that. The first one, a provider said, each team is going to have a little different personality, and everybody has different strengths and weaknesses. And like I told her, it's a dance, and we're learning the dance for the first few weeks. We learn how each other moves and what we can help each other with. The second quote was another provider who said from a different clinic, like when a nurse would go to a different team, there were things specifically about the health IT implementation that they had learned and that they shared with other teams. So I think it was good for them to move around and move information from team to team. So these were examples, a few of our clinics where there were very strong positive relationships, and we saw an association with positive uptake and a more positive attitude towards the health IT and more success. We also looked at power differentials, and some positive and some negative. This is an example of sort of a positive no differential in power at one clinic, where the provider said, we even have in our physical space, providers with nurses, and we're all together. We're a team. So for us to have such a profound disruption, it's not surprising to me we would work together as a team. So that's not really unique, and that doesn't mean much to me. It's almost expected. So there was a lack of power differential. In contrast, at one of the other clinics, there was a much stronger differential where some of the providers refused to implement some of the pieces of the health IT, and they were less successful in their implementation, as might be expected. Our third goal was to look at the impacts of the workflow magnified through these disruptive events like interruptions and exceptions. So overall, we saw an increased level of interruptions following the implementation of health IT. For example, a nurse said phone interruptions during provider order entry could create new medication entry errors. So this table shows the number these are the number of interruptions per hour. And at both organizations across clinical roles, so down here, all roles, we saw more than a doubling of interruptions per hour. Even though it was less than 1 per hour, we went to close to 2 per hour in the post period, and saw similar or even greater impact, significant increases in the number of interruptions at the second organization from 0.34 per hour to 1.05 per hour. So what are the implications of this? Implications and recommendations. So one being the importance of staff engagement. We found that engaging staff in the process of implementing these new health ITs was extremely important and really led to a more successful implementation. Consideration of clinic differences. So all clinics are different, but in particular, we looked at one specialty clinic, and the differences in workflow and patterns at the specialty clinic really were unique, and consideration of those differences really would help the implementation process go better. And then even within similar types of clinics, within primary care clinics, there were differences that should be considered when implementing HIT. Expect the unexpected. So being prepared and understanding that unexpected events will occur and that they may actually provide learning opportunities can be really helpful. We had unexpected things happen in our study, and we learned a lot from those. For example, at one site, a new model of care was implemented together with the new health IT, and it was a medical scribe-like program, and we learned a lot from that unexpected implementation, and we were able to learn how it mitigated some of the impacts of the health IT. Employee minimum specifications. This is really directed at the vendors themselves, that with new health IT, there may be some minimum specifications employed, but then allowing there to be tailoring and customization based on those differences I mentioned and different types of clinics, like specialty clinics versus primary care clinics, will really allow for a more successful implementation instead of pushing a one-size-fits-all. And then consideration of workload. The organization that implemented a brand new EHR reduced the workload considerably, and that very much contributed to a successful implementation of HIT and less impacts on workflow. So some lessons learned. There is a lot of challenges in quantifying workflow. So some are due to human error in capturing tasks. If you can imagine research assistants trying to watch an individual who's quickly switching between tasks on the computer, it's often hard to tell what exactly they're doing and what they're choosing, so that was definitely a challenge. The audit trails were challenging. That's the EHR-generated data. There often wasn't any type of signifying fire for the duration of the event, and the labels didn't always match what we had created for our tasks and activities. And then the two organizations we studied had different EHRs, and they had different audit trail systems, and that made it difficult to compare between two organizations. There are challenges to studying small rural clinics who have a lack of resources, both in time and staff, so it's often difficult to find to follow the same provider in the post period because they had so few providers and people were off and limited resources. The distance to travel to the clinic to even conduct the observations, and then recruiting research assistants was even difficult in some of these small rural clinics, and then having people in the clinics who were unfamiliar with the clinics themselves. We learned to be flexible, and as I mentioned earlier, that there were learning opportunities came from being flexible in what we were studying and accepting the changes as they occurred and using those as learning opportunities. We learned a lot about a new model of care at one clinic in conjunction with the health IT. And then it's two-way value of member checking. So we as the researchers found the member checking very valuable, that was the part where we shared our findings back with the clinic and heard their views of what they thought. But for the participants themselves, the member checking was very valuable. They learned how they could be involved and contribute to improvement of health IT. They felt acknowledged, and probably most importantly, it provided them an opportunity to make sense of their own experience clinics are not often given the time to sit down and talk about how it went with implementation of a new health IT. So that was definitely valuable. And then finally, I can't say enough about the value of a mixed methods approach. I can't imagine doing the study with only the qualitative piece or only the quantitative piece. They really both informed each other and really directed the way that our research progressed. So in conclusion, there are multifaceted impacts of health IT on clinical work processes and workflow. The effects can be both beneficial and detrimental. And ambulatory practices are unique, and there are different impacts that are due to different environments, strategies, and culture. So thank you.
Thank you very much, Dr. Siemens, and we'll move right away to the next presentation. Our next presenter is Dr. Jonathan Wald, who directs the Patient-Centered Technologies in the Center for Advancement of Health Information Technology at RTI, with over 20 years experience in medical informatics and consumer-facing technologies. He has worked in academic, corporate, and research settings where his primary interest is technology used by patients and providers to improve communication, clinical decision support, clinical outcomes, and the patient experience. Prior to RTI, Dr. Wald spent 10 years leading patient portal development, design, and research at Partners Healthcare in Boston. He received his MD from Brown University, his training in psychiatry at Dartmouth-Hitchcock Medical Center, his informatics training at Boston's Beth Israel Hospital, and an MPH from the Harvard School of Public Health. He was elected fellow in the American College of Medical Informatics in 2007. Dr. Wald?
Great, thanks very much, Teresa, and I hope everybody can hear me well. I will advance to the next slide. And today I'm going to be presenting on health IT-enabled care coordination and redesign in Tennessee, based on a project that was conducted in conjunction with Vanderbilt University. And I want to acknowledge my collaborators at Vanderbilt, Nirja Peterson, Lori Novak, Chris Simpson, and Jason Slagle, who really did a lot of the heavy lifting, probably all the heavy lifting as far as visiting clinics and collecting data and being the feet on the ground for this project. And I also worked at RTI with Allison Banger, so just wanted to acknowledge the team. The research question that we focused on is what is the workflow impact of implementing health IT-enabled care coordination within 6 ambulatory primary care clinics? So the focus was on care coordination and looking at the impact of the health IT on workflow. And we also chose a theoretical framework that was based on the SEEPS model and kind of enhanced by Kim Unertl and colleagues to the workflow elements model. So that's already been described, so I'm going to keep it very short. The work that we did was centered around the rollout of a program that was called My Health Team at Vanderbilt. So I just want to describe this because it provides important context for our work. The idea was to introduce care coordination through the role of a care coordinator, and not only to change the role or to add a new role, but to focus on intensified patient engagement and health IT tools that would support the entire care team, including these new dedicated care coordinators. And the focus of the program was aimed at patients with diabetes, hypertension, and congestive heart failure. And it was launched in the context of a homegrown electronic record system and new tools that were also developed in-house at Vanderbilt. So when you think about this program, this overall care coordination program, and ask, well, what's the IT that's supporting that program, it gets a little complicated because there were new pieces, new components that were introduced for the program, and those are in the top box. So you can see there were dashboards and work lists and something called a plan of care, a disease control form. There were alerts and reminders, so there was decision support and prompts through that. There was something called a journaling tab. So My Health at Vanderbilt, MHTAV, is a patient portal, and patients could interact with a new component in the portal to share data, glucose results or blood pressure readings, those kinds of things. There was also an IVR system, interactive voice response system, that was deployed to support the program. And then that was on top of the health IT that was in place and is generally and broadly used. So the electronic health record, the patient portal that I mentioned, there were online patient educational materials, communications in basket, a whiteboard, and so on. And then, you know, the things you would expect, clinic scheduling system and whatnot. So we went basically out into the field in these to follow 6 care teams and look at all of the IT that they used, and it varied, but fell somewhere in the IT that I've described here on this slide. This is an illustration of a screenshot of the plan of care, and so we're going to refer to this in the presentation. I just wanted to show it to you, so you can see some of the ways that that this gets used. You can see, for example, in the top left, that a patient can be active in the care coordination program, or they can be under surveillance, which means they're enrolled, but maybe they're not active, and that the care coordinator can record and track and follow both short-term targets that they can list. There are medication-related goals and activities. The third area is around testing and making sure that tests are ordered and followed up on depending on what the needs are. And then there are monitoring goals as well as a place for other goals. So this component, this plan of care, was the central tool that care coordinators were trained to use and put to work. And this was a lot of where the IT development took place. There was also a work list that I mentioned on the list of different forms of IT. So in this case, this screen shows at a glance what kind of alerts are coming in for a panel of patients that a care coordinator is following. So the patient names are far off to the left. They're not on the slide. You can see who the primary care provider would be for each patient. And then the numbers and letters and colored boxes indicate something about what types of care coordination program the patient is enrolled in and what activities or status they have. And on the next slide, actually the next 2 slides, this shows a protocol that's sitting kind of underneath the technology. So what this is saying is that for patients with diabetes in this program, on the left, that they fall into different statuses. They can either be in the process of being initially verified, which is the top box, or they can be in surveillance mode, or on the next slide, they can be in this mode called titration. And depending on which of these modes that they're in, which status that they have, there are different activities and that should take place and different things that should be monitored. So if we look at surveillance as an example, depending on whether the patient meets a particular age range and a particular A1C value, they may be recommended for physician assessments annually or every 6 months. They have a certain frequency of checking A1Cs and possibly monitoring glucose at home. And then there's a recommended frequency of care coordinator contact. And they work closely with medical assistants. So in this surveillance mode, it was every 6 months. But depending on the status, those factors would go up or go down. And there were these protocols for diabetes and for hypertension and for heart failure. So our study design, also a mixed methods approach, consisted of a combination of direct observation in the field, interviews with staff who participated on the care teams. We did some surveys of staff as well as patients. We also, in some cases, made notes about the spatial arrangements. We tracked some of the software use, especially the use of the plan of care by different users. Basically, our goal was to try to understand impact on these process outcomes. And so, as I mentioned, there were 6 teams, and each of these site teams consisted of a care coordination group. So it was typically a physician, a care coordinator, a medical assistant, a nurse, and these varied depending on how each clinic was set up. We made observations over the course of 12 months in each of the clinics. So we did a lot of data collection initially and also after 12 months. And in some of the clinics, we also made observations in the middle of the year. And the difference, what we were aiming for, was to look at 3 teams that were in so-called more mature or more established sites, which means that they were already using this fully implemented care coordination program at the beginning of the 12 months and still using it at the end, as opposed to the sites that were adopting the program, in which case we got to see them initially before the care coordinator and the program had rolled out, as well as after. And so we had another observation phase in the middle to try to catch how it was going and what kind of changes were taking place. This is a list of the study sites, so you can see they ranged in size. 2 of the sites were actually the same, 3 and 6, just with different care coordinator teams. And the care coordinators sometimes were on site and sometimes they were off site, which turned out to be one of the kind of interesting differentiators in our findings. I mentioned a number of different types of data that we collected. So I'm going to move through that. The data analysis, we generated also a lot of data. And so we went through using Deduce, an open coding, an axial coding, and then a workflow modeling series of steps in order to analyze our data and really try to condense and understand the findings. We also produced workflow diagrams and these interaction matrices for each of the workflows that we identified. So now to talk about our findings, the way we organized the information was into basically 7 types of work. So the first work was relationship building activities between the care coordinator and the patient. And at that point in time, the plan of care in the middle was created and was established. There were educational activities and there was a coaching role for the care coordinators. There was collection and review of home monitoring data. There were coordination activities with other members of the care team. There was a lot of time spent searching and planning in support of these other activities, searching for information and planning activities, whatever the next steps needed to be. So I'm going to spend a few minutes and talk about these findings in more detail. So the first finding around establishing relationships was focused mainly on the establishment of a relationship and then maintaining ongoing engagement once that relationship was established. So there were oftentimes, it began with face-to-face meetings. So during a routine visit, a patient would actually be kind of walked over and introduced to the care coordinator. Later, there was an auto-enrollment process where patients could get enrolled in the program based on the algorithm that I showed you, but without necessarily having a visit or a face-to-face interaction with a care coordinator. And then the ongoing engagement turned out also to be a very significant activity that every time the care coordinators interacted with the patient, whether it was by phone or patient portal or face-to-face, that relationship building gave them an opportunity to talk about how the home data collection was going, or whether they had medication issues that they wanted to talk about, or what was going on in their lives that might be kind of an external factor that was affecting how the patient was doing. We created these interaction diagrams, so I'll talk through this one, but I'll be going pretty lightly through these. On the left are different components of IT. So, for example, the alerts and reminders that were used to communicate with the care coordinator about things that needed to change on their work list, or the auto-enrollment process that I mentioned earlier, or a disease control form that was a communication tool between the care coordinators and the physicians and nurse practitioners. So the IT on the left. And then across the top are descriptions of workflows. So in this case, the main activities associated with establishing formal and informal relationships. And so in the cells that fill out the table, we made comments and judgments about how well the IT supported the activity. And these are just color-coded. So green is good, red means poor alignment, and yellow, as we'll see in some of them, means sort of moderate alignment. And you can look at these individually and see details about how that alignment works. So I'm just going to go ahead to the second activity, because we'll have to, for time reasons, we'll have to take this at a sort of a high level. The second major type of work that we observed was the care coordinator's focus on establishing and maintaining a plan of care. So as I mentioned, these POCs, plan of care, were established when the patient was enrolled, updated by the care coordinators over time, involved a lot of documentation and data capture, and the data came in different ways. And this was kind of the central tool and a primary focus for care coordinators, which turned out to be both good and also created some limitations, which we'll talk about in the discussion. So here, kind of not surprisingly, the alignment between the health IT and the activities of establishing a plan of care and maintaining or changing a plan of care were pretty good. And if we look at the next screen, we're just looking at an example now of the red, the poor alignment. This was around a specific complaint that some of the documentation had to be squeezed into a very small box, and it limited the ease with which the coordinators could enter data and could review data. But, sort of not a hard thing to fix if you have some control over the design of the software. And then in the third activity, collecting and analyzing home monitoring data, this was the work of the care coordinator to allow patients, encourage patients to send in blood pressure readings or send in glucose readings. But it turns out they engaged in a bunch of activities around that. They had to sometimes help secure equipment for the patient. They had to, oftentimes they wanted to calibrate blood pressure or glucometer equipment in the office to make sure that the readings at home were going to be, reliable. Sometimes they showed patients how to use the equipment or how to actually log readings if they had to take it off of the device. And then they would, of course, spend time reviewing home monitoring data, updating the plan of care, and responding as indicated to the readings. And again, we put together these interaction matrices to look at alignment between each of these IT components and the major activities that were important for the overall work activity, the third work activity. In this case, I'll just call out the yellow, the moderate alignment, where there was a blood pressure journal feature in the patient portal, but it hadn't been updated. It allowed blood pressure entry, but not pulse rate entry. And care coordinators routinely recorded pulse, and everybody wanted pulse to be recorded, but the software wasn't quite up to date for that. So the alignment there could have been stronger. The fourth area of time was, a lot of time was spent educating and coaching patients around a variety of topics, helping them to identify resources, and in this case, there was also an important role of the IT in supporting the education of the care coordinator, because just as they're passing along information to patients, they were also educating themselves. And so that was another observation that that was made through the visits. And in this case, the overall alignment was also mixed. There was very good alignment in, say, the CRAMES educational modules that were available to patients through the patient portal, and also available to the care coordinators who were doing a lot of the educational work and the coaching work. But one of the things that they found was that after receiving an alert or a reminder, that the care coordinator would not always be able to know exactly how to direct patients to online resources, or how to close the loop with patients as easily as they wanted to. So the fifth out of 7 areas was coordinating with other clinicians and patients, and there was a fair amount of time spent, as you can imagine, doing this, because patients, especially with these chronic conditions, have a lot of touch points, and the care coordinator's role was to engage patients who were not in touch with the clinic as well as those who already were. And we noticed that there were a number of challenges around team integration when it came to looking at these coordination activities. So, for example, the way the program was introduced, the care coordinators were trained, the software was deployed, the care coordinators were then starting to work with patients as they were enrolled, and the rest of the team, the physician or nurse practitioner, the nurse in the clinic, sometimes they interacted a lot with and heavily with the care coordinator, and sometimes they didn't. We saw a lot of variation over the 6 clinics. And it seemed to matter whether the care coordinator was actually located in the same physical space. It was also not always easy for, say, a nurse who had a patient in the clinic to know how to introduce them to the care coordinator. What schedule would they look at? How would they know where the care coordinator actually was at that moment in time? So those kind of logistical issues, coupled with, in some cases, a lack of full understanding of what the care coordinator's role was, what they were supposed to be doing, and how it was supposed to not overlap, or whether it overlapped with what the clinician and the nurse were used to doing. Those all contributed to some of the challenges around team integration. We also noticed some variation around different sites that probably had to do with how close they were to the Vanderbilt campus, because the testing and the rollout of the program was done more intensively early on, and then later on, as they decided it was important to roll out the program more quickly, some of the more outlying clinics probably received less attention in that process. So I'm a little short on time, so I'm going to go to the last 2 areas of work and then talk about go through our discussion and conclusions. So the next area was more of an overarching type of work, which was searching for information in support of decision-making and action. And this happened in relation to many of the other work activities. And it just highlighted the importance of tools that allow for really seamless searching and, as we said, sense-making out of the information. So every time a care coordinator received an alert or let's say there was a high home reading of a blood pressure, or there was a medication change, that would prompt the need to go and figure out what was going on with this patient, what was the context, what happened recently, and so on, in order to construct a narrative that made some sense so that they could then speak to the patient or speak to one of their colleagues. Just about all of the care coordinators used pieces of paper to write down notes and organize their thinking. We're not saying that that's good or that's bad, just that that was an interesting observation and may surface some opportunities in thinking about how the IT tools either work in conjunction with paper or could support the process differently. And in searching, there was a real mix of alignment. There were some ways in which the IT supported that very well, and others where it was not so good. Much sort of more of a mix overall than for the other work activities that we saw. And then the last work activity that we identified had to do with an ongoing challenge of figuring out, what do I do next? I've got all of these patients, I've got people coming into the clinic, how do I prioritize, how do I plan? And so this kind of daily tasks, what to do first thing when I come in the morning and how to get through my day and what I need to wrap up before the end of the day fell into this area. And what we found was that in this case, the IT was fairly good at helping to prioritize. The alerts and the reminders were certainly helpful in particular. There was an online whiteboard that was supposed to help the care coordinators see which patients had checked in and where they were during a visit so they could connect with them. And that, it turned out, didn't work very well because the way the updates to the whiteboard worked, it didn't quite happen in real time. And so it was much less useful as a tool for the care coordinators. We collected some survey data, which overall was not that informative to the qualitative results that we got. So I'm going to actually pass through that. And we collected some utilization data that was interesting. It showed that the plan of care usage was primarily by the care coordinator and the medical assistant who helped them. And we didn't see any indication that this tool was used by nurses or physicians or nurse practitioners. And that was somewhat surprising to the folks that were designing the overall program and rolling it out. And so one of our recommendations would be for them to use more of this kind of data kind of in stream as they're rolling out the program. So in terms of discussion, we saw a lot of interaction. In other words, there were many work activities, multiple roles. There were, a dozen different technologies. And so it all bundles together to be very complex. Not surprising, but just interesting when you go to measure it and to try to understand where is the alignment strong and where could it be improved. We found that context matters a great deal. I've talked about the physical co-location issue. The strength of the relationship with the patient made a big difference in the care coordinator's sense of how helpful they could be. And that required a time investment and some luck in terms of interacting with folks. The context of timing, understanding when recent events happened and what's going on right now and what's about to happen next, tools that supported an appreciation of that, including the plan of care tool, were pretty important. We also noticed that the intention of the design of the program, it's centered around the care coordinator as a new role and these tools that they use, but it didn't really capture fully the work of care coordination, which is spread across the patient and the other members of the care team and other activities that are not centered on the care coordinator. So there seemed to be a sense that there was an opportunity for the program to mature from the point at which we observed it. As far as the interaction matrices goes, we felt that they were very helpful for showing different kinds of alignment, that in some cases they helped identify missing technology or limitations in the technology. And basically, what I wanted to say on this slide is that the plan of care tool, which was used entirely by the care coordinator, our findings raised the question about how could that tool and the other tools that surround it be more generally useful in supporting care coordination activities. How would you design it differently if the tool was going to be marketed or if use was going to be expected by physicians or for nurses? As I mentioned, there were a number of variations in alignment we traced to differences between individual practices, gaps in system design, variations in the way communication took place. Even the experience of the team mattered. There was better engagement with care coordinators later in the game than there was earlier in the game at some of the clinics. And as I mentioned, there were lots of barriers to information sharing that created context. So in conclusion, what we found was that the IT innovation, the design of care coordination tools and their rollout was a primary driver of the care coordination redesign. That the My Health team at Vanderbilt, the systems, supported the workflow in many, many different ways. We identified these 7 areas of work. We looked at how those played out across all of the providers and the different workflows. And the overall assessment is that there was mixed alignment, as detailed in the interaction matrices that I showed you. I think I've probably mentioned already the reasons for poor alignment that were quite varied, and the reasons for strong alignment also varied. It depended on a lot of local factors and some of the broader factors in terms of how the program was rolled out overall. And finally, that if we were to focus on improvements and what makes sense going forward, we found that it touched all areas, everything from system design changes to varying the way that, or looking at how work activity that varies might become more consistent. User interfaces could change, improving the way workflows and IT work together. There's the issue of training and team communication, and really there's an ongoing activity of creative problem solving and learning, and I think that that is often underappreciated, but needs to be an explicit area of focus. So the process of adopting the My Health team at Vanderbilt program continues, and that's the end of my formal remarks. So I'll just go ahead. This is an extra slide that crept its way in. We'll go ahead to the last slide and show contact information. And I also wanted to say that for the Q&A, we've got Lori Novak on the line as well, in case some of the questions are better answered by Lori, since she was on the ground leading the team and collecting all the data. Thank you very much.
Thank you very much, John. We'll now move into the question and answer portion of the teleconference. Just as a reminder, here's a link for how to obtain CME and CE credits. I'll go back to that in a second. Please submit questions using the Q&A feature of WebEx and send them to all panelists. I'll now begin going over some of the questions we've already received. Thank you to all the active participants. Just wanted to remind folks that slides will be sent to all attendees following the teleconference. Okay, so there are a few questions for both speakers. We'll start with Elizabeth. Elizabeth, were any referral orders to providers outside your health system? And if so, can you elaborate on the creation and building of these orders?
of the orders I was referring to were within the system. The one organization was an integrated system, so a lot of that is internal. I did communicate with that person that I could probably connect them to. I personally don't know about building the orders, but I know people that do, so I can connect that person to somebody.
Thank you, Elizabeth. Okay, our next question was regarding Elizabeth's presentation. As well, regarding slide 28 specifically, can you talk a little bit what you meant, a little bit more about how multitasking was defined for the purposes of the study and the analysis, and whether you have any impressions about whether the decrease in multitasking activities was a positive or a negative thing?
Yeah, sure. So multitasking, so any of the tasks that we had defined, if an observer ever saw a participant doing two at the same time. So if they looked like they were reading the computer while they were talking to a patient, then that would have been multitasking with those two tasks. So we then counted those. We can look at them in many different ways, but we counted that as then a separate multitasking task or event. So in the question, I didn't mean to imply whether that multitasking was bad and that a decrease was good necessarily. I think people argue both ways. And we weren't exactly sure how to interpret the decrease that we saw in multitasking. Some ideas might include that it was more difficult to multitask with the new health IT implementation, and that they were concentrating on learning the new computer system, and therefore they couldn't be doing other things at the same time. But honestly, I think we would have expected perhaps more, because with such a large increase in computer use, I would have expected that they actually would have been putting more things on top of that, and maybe talking to others, to coworkers, to patients more while they were on the computer. So I don't know if either Kai or Holly, Dr. Zhang, Dr. Lanham have any other thoughts on multitasking. I guess
so this
not.
is Holly. Hi. Kai, go ahead.
This is Kai Zheng from University of Michigan. So multitasking, as Elizabeth mentioned, is defined as two or more than two events occurring at the same time. And we don't know for sure, as Elizabeth mentioned, we don't know for sure what accounted for the decrease of multitasking, both frequency as well as duration. And we don't know for sure whether it's beneficial or non-beneficial, because it's a mixed. I think there are some multitasking that are beneficial. There are some multitasking that are detrimental. So there's no clear cut. And we did rule out the possibility of observer artifacts because we use the same observer to observe the same individual before and after. So it's still possible, but it's unlikely that the observer bias might be a reason for this increase. So I just want to make that clear.
Yeah, and I don't have anything to add on top of Kai and Elizabeth's comments.
All right, thank you very much. Moving on, shifting to Dr. Wald's project, was there any significance among different age groups in utilizing the portals? I'm assuming this refers to the care coordination systems that were put into place as part of the intervention.
That's interesting. I don't know if we have data on that in terms of the age of the patients who use the portal, say, for submitting readings, but I'll see if Lori has any comment about maybe some anecdotal observations.
We didn't capture that, or I don't have it handy if we did. So I can't really speak to that. I think that that partially was a product of the relationship between the care coordinator and the patient, you know, to the extent that they were able to get the patient to use the portal. That had to do with how well they were able to communicate and teach about using the portal.
This is John. The other thing I would say is that what I noticed in looking at the data was that the care coordinators certainly adapted to the patient needs a lot. So, in other words, the program required them to try to collect home monitoring data. They didn't necessarily care whether it was through the portal or some other way. I know that Vanderbilt has separately published on their portal and talk about the rate of uptake and the age distribution and that sort of thing. So that might be available if the questioner would like to, you know, look at that separately.
Okay, thank you both. John, can you remind us what was the level of education and experience of the care coordinators that were involved in the study?
Yeah, it's kind of interesting. The care coordinators in this case were all RNs, and I'm not sure. I think that might have been intentional because because Vanderbilt was rolling out this new program, and they wanted to have individuals in the new role who had a lot of flexibility in terms of how they could function. So these were RNs, and therefore they were pretty well suited to the education and coaching role, as well as the other roles, you know, interacting with providers and so on. And again, I'll ask Lori if she wants to add.
They were very experienced RNs, and it almost created a challenge, because to the extent that there was ongoing attempt to increase the automation, the care coordinators as experienced nurses really saw value in that, you know, high bandwidth interaction with patients. You know, they liked talking with the patients on the phone and exploring, you know, what are the challenges, what, you know, how are you doing your grocery shopping, you know, like to really work with them and coach them. And so they did not want to, you know, work in a system where they were just working down a task list. So it was an interesting paradox.
Thank you. And going back to the previous question, do you have any information regarding the age of the users on the provider side and how that might have influenced either perceived value or use of some of the systems that were being used for care coordination purposes?
We didn't make that connection in our data. We didn't really have a very large N in this study. We really concentrated on developing the rich qualitative data. So I wouldn't want to make any claims about age and system use from our sample. We did see, you know, providers of a variety of all across the age spectrum of providers with adopting the system and not adopting the system. So.
Okay, thank you for elaborating. And Lori and John, in addition, can you speak a little bit about the care coordination system, user interface, and potential disconnects in communication across the care team?
That's a kind of a broad prompt. So I'll let me. Lori, do you want to take a shot at that, or would you like me to?
So the tool that was designed was really facilitating the work of the care coordinator, And so what we saw in the groups that rolled it out while we were doing our study, nurses, for example, clinic nurses who had longstanding relationships with the patients it was not part of their workflow to log in and look at the plan of care, for example, or to even think about that patient being a patient who's enrolled in the care coordination program. And so that was a pretty big disconnect, especially early on. And it really required the care coordinator to reach out in an interpersonal way and get to know the clinic nurses and help the clinic nurses understand what the care coordinators bring to the table in terms of the tasks that they can perform with the patients, and in a way, sort of helping the clinic nurses understand what workload they can take off of the clinic nurses. So the nurses can say, "Oh, the care coordinator can do this for me, so I'm going to engage her. I'm going to remember that she's there." And so the system didn't really facilitate that. And so that would be something that I think would be a useful thing to include.
And this is John. I just want to add another example is that it seemed that the care coordination program was aimed at managing a panel of patients. So the work list that I showed with prompts is an example of that. So the care coordinator's job was to manage this panel. But of course, anything they had, any prompt or any alert or any activity wasn't with the panel, it was with an individual patient. And the rest of the team, I think, interacted less with the panel. They did their work one patient at a time. And so I think there's just a natural challenge there, which is how do you get a team, how do you prompt a team to think about a panel and to work together? Are there other activities that are geared towards working with the entire panel, like like changing thresholds, like thinking about general communication challenges, and then, different from activities that are focused on the coordination around an individual patient. So I think there's a lot of learning yet to take place in working through that.
Great. Thank you very much for those responses. One of the participants was wondering more or less what was the duration of the time to complete both studies and how many people worked together to complete them. So I wonder if each team wouldn't mind commenting on that.
Okay, I'll go first. From the first study, it was a 3-year study, but you have to take into account that we had to obtain OMB clearance from the government, so that takes about 9 months in there. So I'd say 2+ years of actual research activities. Remember that we were studying 6 different clinics who were all on different schedules, and we had data collection that occurred in many intervals. So I think you do need to have at least that amount of time with a multi-site study. Our primary research team had 4 members, 4 research scientists involved in the actual analysis, and then of course we had a team of research assistants who helped with data collection.
And this is John. We in some ways were similar. 3-year study, OMB approval, so the observation period was really 12 months, but that was staggered across 6 clinics, so the elapsed time, calendar time, was more like was longer than that. We also had some rollout challenges or delays. The original timing that we scheduled did not match up with some of the changes that occurred in terms of when clinics started their rollout, so we had to make some adjustments. There were 4 staff researchers at Vanderbilt who did the primary data collection and really the primary analysis of the data. Lori, if you have numbers to to add in. I'm not sure if you do, but yeah, I would invite you to do that because I'm not sure what to say there.
No, that's correct.
Do you have a sense, Lori, of you know, sort of how many hours or how busy people were during those 12 months? I know they were pretty busy.
The researchers?
Yeah.
Yeah, I think we were all spending probably at least, we all averaged out about a day a week on the project. So it was a lot, yeah.
Okay, thank you for that information. John or Lori, can you talk a little bit about the training for the care coordinators and how extensive it was, and how it was done, whether there was education or it was on the job training?
I could speak to that. So there was both. They did have training for the care coordinators. So they were all RNs who had experience, you know, working with patients, and they did education around the protocols and the expectations of their interactions with patients based on the protocols. And then there was sort of task teaching related to their use of the information technology.
Thank you, Lori. Elizabeth and John, can you comment on whether you think some system analysis activities performed ahead of introducing the technology would lead to better alignment by enabling better understanding of improvement needs?
Sure, I can start. And certainly, yes, I agree. I think that did happen. It wasn't the focus of our study to look at the what had gone into place to develop the actual health IT that was rolled out. But I would say probably even more importantly is to engage the users during the process. So at the beginning, to engage users in learning about their workflow, having them, you know, try systems and allowing them to make modifications, but to really understand at the user end what the workflow is and how to best align the health IT, because I think what we observed was that it often happens very removed from the actual clinic settings. And so then they felt that it was just imposed upon them without any, you know, attention paid to their specifics and the differences of their clinics, and especially the differences of like I mentioned, a specialty clinic versus a primary care clinic. So I would say that engagement at the time, I think both are important and both can lead to improvements, but not to forget the sort of during implementation engagement.
This is John. I would agree totally with what Elizabeth is saying, and the way I was thinking of it was that there's a lot of learning that takes place. So before deployment, there's a lot of learning that informs requirements development and design and piloting and so on. But ultimately that learning is limited because there are things you can't learn until you go live and you work with data and you work with patients and you learn things that you can't learn kind of in isolation. But so the question then becomes, how responsive can you be during that early implementation and then in month 2 or 3 or 4? So I think that, in my view, the take-home message is that if you envision the process and the project as an ongoing one and build in an expectation that learning will take place and changes do need to be accommodated and made, then that'll put an organization in the best possible position to be successful.
The other thing I might add, and I think there was another question about this, which is the sense making that occurred when we did the member checking. So in addition to the pre and during is after, and what the lessons that can be learned by allowing teams to sort of make sense of the process so that the next time that those can be applied to future implementation. One
thing we noticed was that across the 6 different teams that we observed, there was people discovered the same things. There wasn't necessarily, any mechanism for cross learning. So there's an opportunity for, for Vanderbilt in this case, if they wanted to try to create some mechanisms to foster that.
Okay. Thank you both very much. We're at the top of the hour, so I think we'll end here. I want to thank both our presenters. I want to thank all the attendees for all the great questions and for a good discussion. The presentation slides will be sent to you afterwards and will also be available on healthit.ahrq.gov/events. And thank you very much.